Vivekananda Netralaya. It's a great opportunity for to be introduced to Dr. Arup through TP Das and JV Groups. And thank you for your kind hospitality. What I'm going to do today So what I'm going to do today is to talk about this new drug that you must be familiar with, Retinal, and my journey with this drug, Retinal, how it developed. When in our lab was working on this molecule, angiopoietin 2, nobody gave any attention or any importance to this molecule at that time. We're talking about 2003, even before the approval of Avastin. Avastin was approved in 2004. Colorectal cancer, and then Phil Rosenfeld in Miami at the time introduced one of his patients Avastin injection, and the rest is history. At the same time, the ranibizumab Lucentis clinical trial was going on, but it was not approved at that time. So our work was in 2003. Nobody paid important. But anyway, I will talk about the history. So these are my financial disclosures. So as we all know that patients given anti-VEGF drugs respond very well. In DME, there's an example here. There's one injection, you can see amazing change. 2 injections, 3 injections, it's maintained. And we call this as a good responder. But not everybody responds so well. And it has been shown by large clinical studies, like here is the DRCR protocol I, where you can compare the sham from laser, and there's compared with the ranibizumab, there is a significant improvement in the primary outcome, visual acuity. So it has been approved by the FDA, and but the pioneering work of Judah Folk at Harvard, who introduced the concept of angiogenesis. Nobody believed in him at that time when he started this concept. His ideas were scorned by many. When students were discouraged from working with him, if we had a lecture on his angiogenesis concept, everybody would leave the hall. Nobody believed in him. This is before the discovery of VEGF. And now anti-VEGF drugs are used in cancer patients and AR, PRND, and DR. So that's the history. So again, not all of the DME patients respond to anti-VEGF drugs. So here is an example of a good responder. With one injection, you can see beautiful response anatomically and visual outcome. But on the other hand, we have a poor responder where after 6 injections of Avastin, nothing changed. In fact, the central retinal thickness increased. So what did he learn from the large anti-VEGF trials? Definitely, they are beneficial for DME, they are beneficial for diabetic retinopathy progression, and only about 27 to 40%, about 1/3 of the patients respond well to the anti-VEGF drugs, which would be with 3 lines of vision improvement shown by the DRCRI, right rise, vivid vista. And again, the monthly injections are treatment important. And also I wanted to emphasize that DME is a heterogeneous disease. There are many factors that are involved there apart from VEGF, and that's we need to be sure that it is not a VEGF disease only. Yes, proliferative diabetic retinopathy is a VEGF disease. You give 1 injection of anti-VEGF, it responds, the new vessels regress right away. But that doesn't happen with the DME. 1/3 patients are good responders, 1/3 are poor responders, and 1/3 is intermediate responder. So that is a heterogeneous disease. So in search of a ideal therapeutic drug agent, we need to be sure that it's a longer durability so that less frequent injections are needed, and also stronger efficacy, and we need to look for a target other than VEGF. And why is that so? Because this is a very famous study of Funatsu, published in Ophthalmology in 2003. You can see in the top, you can see the control versus DME, the VEGF levels is all over. The mean value is much higher than the control, but there are very high values, there are very low values of DME, VEGF level. So if you give anti-VEGF injections to the people with the low VEGF level, nothing is going to happen. So must be some other factors out there. And this is another study where it was shown that if you measure the equation of VEGF level, and then interleukin 1B, interleukin 6, 8, MCP1, IP10, all the different other chemokines and cytokines. And if you go through the stages, no dear, moderate to PDR, so as you go down more and more severe disease, you see there is no correlation of VEGF level. 967 no dear, in between 1177 it goes down, and is not increasing in that order, that no dear to the PDR. Whereas if you look at the other cytokines, they're all going up. Suppose take IL-6, 32.1 all the way to 188.6 in PDR patients. So there is an increasing, so again, I'm not saying against VEGF, but I'm saying that other molecules play an important role in the process. So DME is more than VEGF. It definitely is an inflammatory disease, and all the features of inflammation, leukostasis, macrophage and neutrophil infiltration. In fact, our current work is on neutrophil. In our pathology days, we used to think neutrophil is for acute inflammation, but neutrophils have now shown to be a big role in inflammation as a chronic inflammation, so like diabetic retinopathy, and that's our current work is on actually in lab. Macrophages as well as neutrophil infiltration. So, and definitely there are many cytokines that there, VEGF, TNF-alpha, IL-6, and so on. Microglia are activated and complement activated, increased blood flow and vascular permeability and tissue edema. So all the features of inflammation have been described in animal models as well as human diabetic retinopathy in aqueous and vitreous samples. So beyond VEGF, what are the other molecular targets? That's my lab's mission, to find out these targets. And over the years, we have worked on angiopoietin-2, proteinases, CCL2, interleukin 6, all these things we have been working on in the preclinical model, and some of them have been tried in the clinical trials, but the only successful story is the angiopoietin-2. So let us talk about angiopoietin-2 in the next 20 minutes. So Ang2 and VEGF are the key drivers of angiogenesis and leakage and inflammation. So when there is a healthy vasculature, there is a receptor called Tie2 receptor, and there is a molecule called angiopoietin-1 that binds with Tie2 receptor and keeps the vessel stable, normal homeostasis. When there is an angiogenic switch, that means there is hypoxia, suppose. The Ang2 levels go up, its opposite molecule, and that inhibits Ang1, and it binds to the Tie2 receptor. So you will see Ang2 is now, so Ang2 is the agonist molecule, Ang1 is the antagonist molecule, and in combination with the VEGF together, it promotes angiogenesis and leakage. Also important to know that there are three things you need to know about angiopoietin-2 molecule. It's a pro-angiogenic factor that's important for angiogenesis, actual cell proliferation. It's an important factor for viscopermeability. And number three, it's a pro-inflammatory molecule. I will talk about all these features of this molecule and why it is so important, why it has an added advantage, because it has got three functions. And if we target these three functions, we can develop a good solid drug that can effective in diabetic retinopathy. So this is our work. This is my partner at the Nord Lab, Paul McGuire. We published this in 2003, our first paper in an animal model of retinal neovascularization. It's very similar to the Arup model in the mice. We found the angiopoietin 2 level goes up in the retinas. And here is an example on the left. A is a section of the retina, normal retina. These animals are not treated with any drugs. You can see the arrows on the top. That's the inner limiting membrane cross. Those are the blood vessels, blue vessels on the inner limiting membrane. And you can see several of those are there. Now, if you have an injection of the drug against angiopoietin 2, then you can see almost 86% inhibition shown on the right by the bar diagram. So the arrow is only one tiny vessel there, but you can see a significant reduction of angiogenesis in an animal model. It was shown by our lab in 2003, as I was mentioning, even before the approval of Avastin. And further in our lab, the second function we looked at is the permeability change, where this is my postdoc, Sampath did the work, led the work. He was trained at MDRF in Chennai. Here's the endothelial cells. You can add angiopoietin to alter the V cell junction protein called vascular endothelial catechol, and it alters the barrier just like the VEGF. And it was published in 2011 in IRBS. And the third function we talked about is that Ang2 is pro-inflammatory. Here is my another postdoc, Finney, from MDRF. What he did, he looked at the endothelial cell and monocyte additions. As the monocytes are circulating in the blood vessels, they can adhere to the endothelial cells in diabetes. The endothelial cells become very sticky, they bind, we call leukostasis, and that process is mediated by angiopoietin 2. This is another interesting feature of inflammation. Whenever you see in the retina, this is a non-diabetic retina from a mouse model. The red are the retinal vessels, and those green cells with the processes are called the microglia. Microglia cells are staying green in this part. Now, if you inject angiopoietin 2 intravitreally into the mouse eye, you see this exactly. You see two important things. If you look at the figure, see higher magnification. Those microglia are now activated. They are like a turned amoeboid. They're rounded up. The processor lace is not like an inactive cell, so they are activated. So microglia is activated, and you will see a lot of the small round red cells. Those are monocytes from the blood vessels. They are coming out in the extravascular space. So monocytes are trafficking, crowding in the retina, and exactly the same thing happens in diabetes. Diabetes also monocytes trafficking and microglia activating. So if you have an angiopoietin 2 inhibitor, you can inhibit the monocyte trafficking, you can inhibit the microglial activation and all the subsequent steps. And Ang2 levels are increasing vitreous of patients with retinal disorders. If you look at different diseases compared to the control, on the right hand side, you can see ARMD, vein occlusion, PDR, all the levels are going up in Ang2. So, if you have a molecule, faricimab, Vabysmo, it has a anti-VEGF Fab, it has an anti-angiopoietin 2 Fab, and it has an FC optimized for faster clearance from the systemic circulation. So this is developed by Roche, and this is the first bispecific antibody for intravitreal use. And they got into a clinical trial in DME. At the same time, actually, Retinal also tried but they have a different 2 injections. The advantage was this is only one injection, Retinal had 2 injections, one for anti-VEGF, one for anti-VEGF2. I was involved in the clinical trial for both of these companies. Suddenly, I got attention after so many years, nobody paid any attention. Suddenly they said they want to get into these clinical trials. So here is the one we are talking about, Vabysmo in the market right now. And you can see in the animal model, if you do the dual inhibition of angiopoietin 2 and VEGF on the top, you can see the fluorescent angiopoietin, all the leakages you see. And the anti-VEGF, still there is some leakage there, but with the combination of anti-Ang2 and VEGF-A, the leakage is almost gone. And the other fact that they are also looking into this, the epiretinal membrane formation is decreased in diabetic patients. There's a lot of interest in that if you are using a dual inhibitor of Ang2 and VEGF. So that figure on the right hand side showing the staining of molecule fibronectin, you can see on the top. And then if you do the dual injection, you can see the staining is very little with dual inhibition. So it inhibits the fibrosis formation, epiretinal membrane formation in diabetes. So that's another advantage we're looking at. So in fact, I'm still working with the Roche company on developing and further modifying this drug, Vabysmo. We're doing some laboratory experiments in collaboration with Roche. So these are the two important trials, phase 3, Yosemite and Ryan in DME patients, and they was divided into 6 milligram faricimab, Q8 weeks, and then also there is another called the green one, is the PTI, personalized treatment, and they are compared with the 2 milligram Eylea, aflibercept, Q8 weeks. And in both studies, there was reduction, greater reduction of the thickness and the intraretinal fluid observed with the faricimab. The vision improvement was the same. Surprisingly, we did not see any vision improvement over aflibercept, but definitely it's a much better drying agent than aflibercept. So these results are published in the Lancet in 2022. You can see on the top those two figures showing the green one is the faricimab, and you can see the visual outcome is very similar to aflibercept. But if you measure the aqueous humor level of angiopoietin 2, on the left hand side is the wet AMD patients, on the right hand side is the DME patients. And they looked at the aqueous humor sample. You can see if those, that's a baseline, the blue bar is the baseline, and is after injection, it was BLQ, that is below limit of quantifiable level. That means you cannot detect any after faricimab treatment any angiopoietin 2 level. The angiopoietin 2 is suppressed in the AMD patients. Whereas in aflibercept, you can see angiopoietin 2 levels should not be suppressed because there is only anti-VEGF agent. So they are still up. That's the question. If you are still at high levels of Ang2 in the aqueous or vitreous, that's still causing the leakage. So you need to neutralize that molecule as well as VEGF. Same thing for DME, you can see on the top with the faricimab injection, the aqueous level of Ang2 almost undetectable, whereas in the bottom aflibercept, you still see high levels of Ang2. And that's expected. So in both the trials, Yosemite Ryan is a DME trial, and Tenaya and Lucerne is a wet AMD trial. You can see the purple one is the faricimab. You can see much significant change from CST, thickness change compared to aflibercept in both. More decrease of CST. And then, if you look at the overall, all the patients in the Yosemite and the Rhine study, these are the DME study, you can see you can go even up to 53% of the patients up to every 60 minutes, which is about 4 months. And you can keep the retina still dry with faricimab injection. So, Yosemite Rhine study is a DME study. This is the 1 year, this is the 2 year, I'm just showing the arrow. So if you go to the 2 year results, you can see you can be going up to 12 weeks to 16 weeks in about 78% patients, which is a very significant number. If you go to the Chennai and Research study, which is a wet AMD patients, you can see same thing about if you go to the year 2, Q12 weeks and Q16 is about 77.8% achieved. You can go without doing frequent injections, you can go even up. That is the goal, to do less frequent injections to decrease the treatment burden. And this is the recent results of the same thing on the retinal vein occlusion study. These are called Balaton and Immunostatin. And again, the whole purpose showing that more significant 57-58% patients can be gone. You can go to Q12 to 16 weeks interval. Let me show you an example. Our center was one of the clinical trials for the Yosemite study. And here's an example on the left. Actually, this is a Boulevard study, which is the phase 2 for the medicine. So this patient, you can see in the top figure, vision 20 by 125, 579 micron, one injection, it came down to 300, 2060 level, the second injection, still coming back. After the month 3, you can see it is maintained. So in all this time, according to the trial, we are giving every month, every 4 weeks, injection of faricimab. And then after 6 months, we are told, you do the injection as needed, according to the investigator. And here is that same patient on month 6. Visual acuity is now 20/50, 205 micron central retinal thickness, and I was not using any injection. Month 7, month 8. So the last injection was here, month 5. So 6 injections here, and then I'm just watching the patient, month 8, month 10, month 11, maybe a few cystic changes are seen now. The vision is well maintained, even month 12. So the mind is not everybody going like this, but many of the patients you can go up to 4 months or 5 months without doing another injection. So if you look at the leakage, Yosemite Ryan study pulls post-hoc analysis. They showed that in the day 1 and week 16, definitely there is a significant reduction in the leakage as shown by FA. And they did a post-hoc analysis, it's called macular leakage area assessment by Wisconsin Building Center. They measured the amount of leakage areas. On the right-hand side, you can see the green bar is the faricimab treated, and the ash color is the aflibercept Eylea. There is about 53% more reduction in the macular leakage area if you compare it to the 2 drugs. So definitely it is a better drying agent. Now if you go to the PED for wet AMD patients, there are many patients they found out that PED from that minimum PED collapsed like that. Not for everybody, but it's a significant number. If you now do a pooled analysis from the 10-year Lucent study and measure the presence of the serous PED, you can see with the faricimab shown with the purple bar, 3.9% as opposed to the aflibercept 12.3%. This is almost 75% reduction in the PED. So the another thing that they are looking at right now is the, as you know, this is called hyperreflective foci, white dots in the OCT. What are those hyperreflective foci? They could be lipid, they could be lipid-laden macrophages, they could be activated microglial cells, all kinds of lesions can give rise to the high HRF. And if you look at the HRF, according to this Yosemite Ryan trial, they have shown that faricimab treatment has a significant reduction in the hyperreflective foci because it's an anti-inflammatory. Again, as I talked earlier about the fibrosis, the fibronectin staining as shown in the animal experiments. Here is an example. You can see that dual inhibition reduces the macrophage infiltration compared to the VEGF. So it prevents the formation of fibrosis also. And here is an example of a patient. you can see in a diabetic patient developing a retinal membrane over time. And if you look at a post-hoc analysis of the urosubiturine study, you can see the right-hand side of the ash-colored bar is the aflibercept, whereas the faricimab, those two different treatment protocols, both have a significant reduction in the epiretinal membrane or fibrosis formation. So here's an example of one of my patients in my clinic, patient with 2150 vision, significant thickening. We started with Avastin. I always use Avastin as a first line. Many physicians in the US do that. I know that you have used many times Promethazine or Eylea, but I use it. And insurance companies, they want us to use it. Try the first cheaper drugs like Avastin. And I think Avastin is equally effective of any of these drugs, expensive drugs. We try 3 injections monthly, and if they don't respond, then I switch to Eylea. And then if they don't respond to Eylea, then I go to Vabysmo. That's the, and the insurance companies also want us to step therapy, so that they want to be sure that I have tried the. Anyway, I tried the Avastin here. Nothing happening. 1 injection is going up. Vision maybe improved, but still there's a thickness. So I kept injecting Avastin. Now I started faricimab in this patient. There is some decrease, 390 micron, yes. Vision is 20/80. And with the second injection, you can see definitely there is an improvement. You will not see the changes right away. I think it takes 1, 2, maybe third injection, you start seeing reduction in the central retinal thickness. Here is an example of another patient, CRVO, in my clinic. You can see we have been injecting Eylea this time, and I have used 5 injections, 12 injections. And at that time, what's happening, Vabysmo was not approved while I was injecting, you know. And then as soon as Vabysmo got approved, Genentech said that maybe we can now our hospital then allowed Vabysmo at that time, and I switched to the Vabysmo. And you see, nothing happened with 1 injection on the retinal. 2100 still there. Now you see the difference. Second injection, the vision came back to 20/20 with complete resolution of the retina. So in this case, what does it tell me? It tells me that it is not a VEGF dependent disease here. It has VEGF plus Ang2, and that's what happened when you have dual inhibition of the Ang2 and the VEGF. So still maintaining 20/20. I've been giving injections every 8 weeks now with Vabysmo. These are not always happening, but many of the cases I've seen, I would say those patients who are not responsive to Eylea, they respond well to Vabysmo in about 1/3, 30 to 40% patients. Because there are many other molecule cytokines are there. Interestingly, this is a comparison between all this. This is a database called Vestrum. You can see faricimab there, aflibercept, ranibizumab, ranibizumab. If you look at the incidence of retinal vasculitis, is very high in brolucizumab reported. 16 out of 4,700 cases, as opposed to we have seen 2 cases in faricimab also. Same thing for vasculitis and vascular inflammation. Very significantly high for brolucizumab. Unfortunately, the retinal physicians in the USA are very scared of using brolucizumab. Myself also. When we have a better drying agent like faricimab now, I don't use. Sorry. Okay, so here is the story, moral of the story. Me and Paul, we never got support from the Ang2 We published our work in 2003 and 2011. Our NIH grant proposing this therapy dual inhibition was triaged by NIH. They said that VEGF is the only story. It is 2016, I'm talking about 16 around that time, that I got a phone call from Genentech as well as from Regional, that they're getting into clinical trials using the dual inhibition of anti-2. And then 3 different drug companies started trials, and now it's an active drug. So moral of the story is that never give up. So what I'm going to do now is to show you just a few things that just enter in the pipeline. High dose, you will hear about that high dose aflibercept 8 mg also has a good drying effect. It has been approved in the market, high dose. I don't know whether you got it here or not, but
Not yet.
it will be coming soon. It's been approved almost less than a year. Suprachoroidal injection. This is the drug I'm going to talk about. OPT-302. It's a Opthia company. They have started a new antibody against VEGF C and D. So all the drugs that we are talking about here is again VEGF A isoform. There's a VEGF C and D are also involved in angiogenesis. Whenever you're injecting anti-VEGF A, there's a compensatory increase of VEGF C and D isoforms in you, and that causes still permeability change. So you are not neutralizing those. So if you now develop an antibody against VEGF C and D, you can combine with the Eylea, whatever, or ranibizumab, you can get a pan VEGF inhibition. So that I'm going to talk about in a minute. There is also anti-VEGF polymer trial going on, targeting VEGF and IL-6 together. There is a tyrosine kinase inhibitor. There is an integrin antibody and the callictin. There are several other drugs are being in clinical trial in these diseases. So suddenly ophthalmology is seeing a huge market for all the drug companies. They're all trying different molecules, and the whole goal is to increase the durability of our anti-angiogenesis agent, so that less frequent injections. So I'm going to the next 5 minutes to try to quickly talk about my current work. I'm not going to show the results here. I'm going to show the questions that we're asking. Is there a role of genomics? We know the A1C plays a big role in diabetic retinopathy progression, but that's not the whole story. I think also genetic factors play an important. Many patients with PDR I have seen have low A1C level. Similarly, we have also seen that many patients with high A1C level, 10, 11, 12, nothing in the eye. They're protected. So it must be a genetic factor playing a role. So that's my, the last 5 years we are working as a patient, type 1 diabetic for 38 years. You develop some retinopathy by 15 years, 10, 15 years. Not a single microaneurysm in either eye. So this is we call extreme phenotype. That means no retinopathy, or maybe 1 or 2 microaneurysms. We got about 103 patients between us and Lloyd Ayala's group at Harvard. So we are collecting the blood samples and the DNA sequencing or analyzing and comparing with the other extreme end of the diabetic retinopathy is the proliferative diabetic retinopathy. Also important question I wanted to ask that you see all the time with the huge new vessels on the PDR patient, but look at the macula, there is not a single hard exudate. Why is that? Why is that? If the VEGF level is high, is causing angiogenesis, why is it not causing leakage at the same patient? There is no exudation there. There are many patients are like that. Actually, 75% of the patients with PDR do not have a single hard exudate, do not have macular edema. So we have shown in our patient group. Similarly, if you have a very exudating patient with so much thickening and exudation, doesn't have all this angiogenesis. Same thing, 80% to 20%. 80% of the patients will not have an angiogenesis at the same time. Why the same VEGF is not causing angiogenesis? We do not know the answer. And this is the study we're doing now in New Mexico and at Harvard together. Caucasians from Jocelyn, and we have Hispanics and urban American Indians. We're trying to answer the different questions. Why are some diabetic patients protected in spite of long duration of diabetes? We call extreme phenotype, and we actually found an answer that I presented recently at the Macular Society meeting. And there are, we think that PDR and DME are 2 different diseases. So if you treat PDR with anti-VEGF, it responds very well. If you treat DME with anti-VEGF, it doesn't respond. Good versus poor responders. So definitely there's a different mechanism, different pathways of that. And the third one is that the anti-VEGF response in DME patients is more like good responders and poor responders, because there are different molecular signature in each type of DME patient. Not every DME patient is the same. And this is an example of in the poor VEGF responder, we measured the different levels of the cytokine, like VEGF-A, VEGF-165, angiopoietin 2, VEGF-C, all those things you can see in the orange bar are all the poor responders are up compared to the good responders shown by the blue bars. So definitely there is more inflammation going on in the poor VEGF responders. Here's an example of a patient, a poor responder. You can see with injection of anti-VEGF, nothing is happening. We looked at the level in the whole exome sequencing, we found a variant called VEGF variant, VEGF-R3, is a receptor 3. The receptor we always talk about is VEGF-R2 for anti-VEGF drugs, but this is the VEGF-R3, which is a target for VEGF-C and D. That's the story coming out. So when you measure the levels of VEGF-C, in this patient you can see VEGF-C level was up along with the VEGF-A. So VEGF-C is an important molecule. I think I bet in the next 3 to 5 years we'll see the inhibitor of VEGF-C in the market. Is another example of a poor responder. Nothing is happening with the anti-VEGF injection, and we looked at the whole exome sequencing. We found a HLA-DRB1 and a CCL2, which is a MCP monocyte tracking is up. So why don't all patients respond to the anti-VEGF drugs? My explanation is this. Some of them have very high VEGF levels, so if you are trying to neutralize, it's not getting neutralized. There could be also VEGF-C level high, because whenever you're injecting anti-VEGF-A, VEGF-C and D goes up in those patients, and you are not neutralizing that with your standard anti-VEGF drugs. Second, as I mentioned, there are many other factors of their inflammatory phenotype, and Vabysmo is targeting the Ang2. So that's not being neutralized by anti-VEGF drugs. And again, VEGF secretion continues, and there is no reperfusion as shown on the right-hand side. Anti-VEGF drugs do not cause reperfusion. It might maybe slow down the progression of non-perfusion, but it does not cause reperfusion in the vessels which are lost. So, and there is a compensatory VEGF base. So this is the molecule that I'm talking about. So if you can, VEGF inhibition upregulates the VEGF-C and D. That's a very important finding. And you are using the aflibercept against VEGF-A and B, and Opthea 302 against VEGF-C and D. So if you combine both, you are getting a pan-VEGF inhibition. So it is an example. Eylea is acting on VEGF-A, VEGF-B, and placental-like growth factor, mainly the VEGF-R2, also VEGF-R1, whereas VEGF-C and D acts on the R2 and mainly on the R3. And here is an example of Lucentis is only targeting the VEGF-A, and whereas Opt-302 is targeting the VEGF-C and D. So a combination of Eylea plus a combination of Eylea and Opt-302 inhibits all forms. So there are several trials going on now. The one trial has shown that its effect is called sozinibercept, not aflibercept. It's an interesting name, the Indian name, I think, sozinibercept. And then phase 2 trial has been shown to be very effective. Finally, the phase 3 clinical trials going on in wet AMD, SHORE and co-study. So this is something we're going to hear. So again, I'm going to finish here in a minute. In contrast to the one-size-fits-all approach, we need to determine the individual variety of genes based on the cytokine. Maybe a day will come and take a cytokines assay from the H1Z or something, and then decide who is high VEGF, who is high Ang2, accordingly use different drugs. In 5 years, that's the dream. And it's called precision medicine. So here is a patient with maybe somebody with the red bar is a high VEGF level, and the small one is a high, low VEGF. somebody with the IL-6 is high. So there may be a different molecular signature, and you can measure ahead and utilize the drugs. So we have seen 15 years of anti-VEGF therapy, and many questions are unanswered, and that has set the agenda for how anti-VEGF may be enhanced to improve the patient outcome in the next decade through solving the drug resistance, coming up with novel biomarkers for anti-VEGF response, combined therapy, and targeting beyond VEGF. This is Judah Folkman, who started the whole field of angiogenesis. I happened to interaction with him during my research career.
Once in a while there is a tremendous finding and you realize for the first time in your life that you know something that hour or that day that nobody else in history has ever known, and you can understand something how nature works. That doesn't happen to many scientists, and if it does, it's a blessing, and if it happens more than twice, it's a miracle. And when it happens, it's a very big high.
So in my case, it was happened to be a blessing that I stumbled on the angioprotein 2 therapy. That doesn't mean that I have discovered the molecule. It was there in the tumor angiogenesis field the same way. VEGF was in the tumor angiogenesis field. Our lab and I was at the right time happened to be working on the ANG2. This is an old picture in Judah Folkman at one of the academy meeting. And these are my people in the DRG study. We were looking at the genomics, the UNM Jocelyn Diabetes Center, TJ in Phoenix, where we were doing the genomic study, NIH, Anand Selvi, and Orton, IHS. These are my past and present members, collaborators. This is the Balloon Festival in Albuquerque, in Mexico. Every year in October we have this beautiful 2-week festival. Thank you.
Thank you so much, sir. It was an illuminating experience to listen to you, and how effortlessly you married basic science and clinical applications. And this is a pure example of translational medicine, I would say. And I think we are all bubbling with few quick questions, and we don't want to delay you, but if there are any questions, please go ahead.
Sir, I had a question.
Yes.
You said that because of insurance pressures, we use Avastin first, and then the idea after that. Given no insurance pressures, would you go straight away with Avastin in some patients, select group of patients where you think that there's no point wasting time on?
Definitely. It all depends upon definitely insurance. You don't want to burden our patient with the huge bills. And many drug companies actually, Genentech, even Genentech and Regeneron, they have all different programs for those kind of indigenous patients. There is a special program they can give free samples actually. We have to apply to the insurance company because it's needed in some of those patients. In India, I don't know what the situation, and I was still a little bit surprised that we are not using Avastin at all. I mean, we in the USA, we always use Avastin as the first line of therapy. There's a compounding issue, infection issue, and all those things are there. That was many years ago. It happened in USA when we started with Avastin, but nowadays it's pretty safe. I have been doing every week hundreds of patients. I started them with Avastin. If they don't respond, then I go to Eylea, and then now I have a third line of treatment, Vabysmo is there. Yes.
So we have been using Avastin till about a couple of years back, sir. And what made us leave it was that we don't have compounding pharmacies very readily available in India. So there was a problem with spurious drug, making it into, that was another issue. And so there were epidemics, cluster, endophthalmitis following that spurious drug usage. And in fact, PGI was dealing with a major problem, and then it was just kind of plucked out. And so we've not been using Avastin for the past couple of years. And that's where the biosimilars, which are now becoming very important in the US as well,
Yes.
they came in to our rescue, I would say, because so many poor patients can't afford these expensive drugs. despite the patient support programs. And that's where these biosimilars have really come in handy, and they provide an alternative to the patients who can't afford these expensive injections.
I completely understand the issue of quality control in compound. We had the same issue. We have started to use the biosimilars. I haven't used much biosimilar yet, but it's an exciting field. In the next 5 years, we will see many more drugs. Opthia is there, very important one I can see. Our lab is working on several molecules also still. We talked about neutrophil, that's another one we are talking about. This important chemokine called CXCL1 that's involved, so that we are targeting. Genomic study showing very good results. Who get PDR, who get DME, you can maybe a future will come and do a blood test and see this patient. Not everybody gets PDR. If you follow PDR, a diabetic patient over 30, 40 years, you'll see 50% of the patients, only half of the patients, I'm not talking about irrespective of the control of A1C, will develop PDR. Other 50% in their lifetime will never develop PDR in spite of high A1C. That has been shown by Wisconsin epidemiological study. So the question is that what protects them from not developing? Maybe some genes are there, variants. I'm not saying they are causal variants, it could be modifiers that modifies. So a combination of high A1C, a combination of genomic factors may precipitate the whole pathology of PDR or pathology of DME. Same way, some patients are protected. We found one gene variant. We are now writing the paper and trying to publish that. I know it will be a lot of resistance. Whenever you come up with a novel idea, and that's good. That means it's going to happen. There will be a lot of resistance to against people that all of you believe in A1C. I have nothing against A1C, but this paper that I'm writing right now, it talks about A1C has no role. It's a bold statement, but we'll see. Thank you.
I had a couple of quick questions if you can have the time for that. So we have been seeing some IOI, and over the past 1.5 years or so, we've used brolucizumab, and we've had a couple of cases of vitreous cells, vitritis, which responded to topical steroids. So we were not really alarmed. But this year, just the past 6 weeks, we had our first case of occlusive retinal vasculitis post third injection of brolucizumab. So which really kind of alarmed us, and fortunately the central vision was not involved in that patient, and we were able to get away with systemic steroids and topical steroids. My question to you, sir, is that we also had 2 cases which had vitreous cells post faricimab injection. I just saw some recent reports of even occlusive vasculitis reported post faricimab. One of these patients was brolucizumab naive, but one had received brolucizumab earlier. So the question was that what we are seeing, is it because of the large molar dose of the drug? Because the molecules are quite different in the sense that the brolucizumab is a small chain fragment. It's a very small molecule, and it is packed, and has a very high molar concentration. Whereas faricimab is not such a small molecule, but the dose is still high. So is it just the dose of 6 milligrams, or the higher dose which is responsible for these IOIs? What is your gut feeling or your experience in this?
So when we were writing the review paper, it came out in ophthalmology, I think a few years ago, on the review article on brolucizumab. I was one of the co-authors. We did not report, or we did not find any such event in clinical trials, Hawk and Harriet trials. So our paper was accepted, almost writing the final publication. Suddenly we got reports from all over, vasculitis, vascular occlusion, and we got all nervous. We published our paper, but after that, a series of incidents we found out that vascular occlusion, vasculitis, most likely is the immune reaction. I'm not sure whether this is because of the higher dose. It's about the molecular, Again, it's more cases were found in the brolucizumab compared to faricimab. So far, 2 cases, whole, all thousands, I don't know, 200,000, maybe a lot of cases, 2 cases reported, whereas it was much higher in a smaller number of patients in faricimab. We cannot, so even the aflibercept also has a few cases reported. Now we are, once you know the cases with brolucizumab, we are reporting more and more, looking out for those kind of side effects. But again, statistically, much higher number of patients in brolucizumab. So in USA, retina physicians, definitely I don't use it anymore. And many other, I would say 99% do not use. There are some patients, they have found already they are very good response to brolucizumab. In their practice, they are keeping those patients maybe 1 or 2 and using brolucizumab, otherwise they have stopped. It's most likely immune reaction, exactly nobody knows the mechanism, and it is not unique to any particular brolucizumab. Now we are seeing in other patients, so we have to accept that. But again, it's much higher incidence in the brolucizumab. That's what we can say. Yeah.
What is your experience with HD Eylea, because that has not been released? So, and how do you compare it with drugs like faricimab?
I think it's also equally effective drying agent, longer duration, photon trial, and Regeneron. The problem with that the drug, high dose HD Eylea, is that it comes out in the 0.07 ml. Is that right? Yeah. So now we are using 0.05 ml for all injection. This is a 0.07, almost 50% increase in the volume. So you are introducing a drug with a much higher volume. And that's going to cause intraocular pressure rise and all the side effects that there may be more. So that's why we have to be very cautious about that. That's one side effect you will see, and you have to do maybe more paracentesis for those kind of injections because it's a higher volume. But I think efficacy-wise, they are equally effective. Regeneron found a competitor now, faricimab, and they came up with right timing with this. So we'll see this kind of competition among the companies, and I think it's a very good drug, but again, the volume is higher than the normal. You have to inject more and more to increase resistance.
I think that may not be a very big issue in India, because we used to give Avastin with intravitreal triamcinolone all the time, and we are so used to doing paracentesis before giving these injections. So I don't think that will be a big issue here.
Okay.
So my last question to you, sir, is that in the time to come, pending the availability of these newer drugs which you have outlined and in which you are also involved, do you think that for now in India we are using these newer drugs on a PRN basis? We don't do the loading dose and the regimented protocol wise. So do you think that a sandwich technique in which when the patient is not responding, which we are actually using in India, that when he is not responding, we just try one of these newer molecules, and if it is dry, then after that we maintain on a safer agent, I should say, as far as IOI is concerned, like with Eylea. Continue with Eylea, we just bring down the swelling with, let's say, faricimab, and then continue the patient on
you can switch back to the older agent. But I don't know, something has come up, especially for the wet AMD patients. We always talk about drying effect. Or we think that with OCT, the fluid is gone into retinal fluid, subretinal fluid. But I like you all to read one paper, very important paper, this CAT trial, 5-year results, came out in ophthalmology, I think 3-4 years ago. So CAT trial, as you know, compared between the Avastin and Lucentis, and they looked at 5-year results, and they found very important findings. It's a big thing now. So with 5-year injections, even 80% patients could not be dried up. Still there is a residual fluid even after 5. So it means that anti-VEGF injections, you don't have to think about it. If it is not dry, I just keep injecting. It's not necessary. If the patient's vision is stable, patient is asymptomatic, patient doesn't have any, I'm talking about wet AMD, no subretinal hemorrhage, and if you have dried up the intraretinal fluid, that's the sign of activity. Any subretinal fluid is not a sign of activity, they are saying. In fact, they looked at the patients who had subretinal fluid after injections and those who were completely dried up. They compared between these two groups and they found those who have subretinal fluid have less atrophy, geographic atrophy, compared with those who are completely dried up. They have more atrophy. Very important finding. What does it tell us? That a presence of a little subretinal fluid, and we do not know the exact mechanism, what prevents the retinal atrophy. So if you have a little subretinal fluid, but your intraretinal fluid is dry, that should be your goal. But if there is still subretinal fluid, that acts as a barrier for all the bad stuff coming from the choroidal circulation to the retina, and it prevents the geographic atrophy. That explanation is being given now, and I think that's an important lesson to be learned from this CATRA, that you don't have to, you can go to PRN if the patient is stable vision, 20/50, the patient is not complaining of any distortion of symptoms, if the patient doesn't have any subretinal hemorrhage, you can just watch in PRN after several injections. You don't have to run after that tiny amount of subretinal fluid and justify another injection. It's not needed because those patients who have fluid have less atrophy, which is very interesting finding, I think. So now these days there's a more importance are given to the concept of subretinal fluid versus intraretinal. Please read that paper, CATRA. It talks about also same thing about it. Avastin has actually better, the less atrophy. And it talks about, Avastin is not, we think that it's less expensive, so it's, the higher expensive, but they're more effective, not necessarily. They are equally effective, at least for wet AMD patients, for Avastin and the other anti-VEGF. And more atrophy was found in the Lucentis-treated patients. These are not talked about, and the companies don't want to talk about these things. That paper talks about these important conclusions. And there's a new concern that you must be knowing that there are many patients who are dry AMD patients who have been fogging, and suddenly you see a tiny subretinal fluid on OCT. And you think there's a new conversion, you start giving anti-VEGF injections. Now a paper has come out where they're talking about you don't have to do anti-VEGF injection. It's just the presence of tiny fluid. If the patient vision is fine, if there is and if you do an angiogram, there is no CNV there. It's called non-neovascular type of dry. It's a fluid there. So on that definition, you say, oh, this is a wet AMD, but it still is a dry AMD, and there is by fluorescent angiogram there is no CNV. So this is called non-neovascular type of dry AMD, which you can observe closely, and if there is a big change in vision or a presence of intraretinal fluid, then you treat. So just like diabetes, retinopathy, we have NPDR, PDR, same way they're talking about non-neovascular, neovascular, you don't have to do the injection. It's a mechanism of RP pump failure. In that area, the RP cells have a defective pump mechanism. That's why it cannot dry up the fluid and the fluid accumulates, and it's not necessarily a bad thing. But you have to watch closely for development, for which, but that's another interesting way. All the big shots in the field of retina have come up with that paper. I think it came out in the BJO or I'm not sure which one, I don't exactly, but there's a few years ago. So again, the drying, you don't have to, the goal is not necessarily the complete drying. You can still have a little fluid. That's good for actually, that protects from the atrophic formation. Thank you.
Thank you so much, sir. So I would like to request Dr. M.S. Nawal sir and also Dr. Sushil Oja and Dr. Neeraj to please come in forward, and we'd like to facilitate, sir. And I would request Dr. Gaurav also to please join us. Can we have the lights, please?